Good morning, everyone. All of our participants on Zoom and in person. We're so happy to have you all with us. And in particular, Dr. Lupo Geronazzo-Alman. He is our speaker this morning, and he will be talking to us about. Um, okay, so let me just go ahead and introduce. So Dr. Geronazzo-Alman is an assistant professor of clinical medical psychology in psychiatry at Columbia University, and his research interests include identifying and characterizing the early indicators of psychiatric vulnerability and biological and behavioral correlates, including morbid markers of vulnerability and the trajectory of mental health. He has conducted highly innovative research at the interface of psychiatry, epidemiology, and advanced data science, including machine learning and computational causal discovery methods, to better describe psychiatric phenomena and their etiology. Dr. Geronazzo-Alman is currently an MPI of the NIOSH-funded study RDOC domains underlying emotional health and trajectories of psychopathology in families of the World Trade Center first responders and evacuees. So I'm going to hand over to Dr. Lupo for his presentation this morning.
Thank you. Can you see the slides?
Yes, we can.
Okay, great. Yeah, good morning, everyone. Thank you for attending this talk. I don't know whether do you see like a green line on the slides? I don't know. Well, anyway, I hope you can see the slides well. So today I will talk about the distinctiveness of grief, major depression, and post-traumatic stress disorder. This is a study that was done in a sample of children and adolescents that were assessed 6 months after 9/11. A lot of the findings that I'll talk about today have been published on this issue of the Journal of the American Academy of Child and Adolescent Psychiatry, in case someone is interested in finding out more details about the study. So persistent complex bereavement disorder has been introduced in DSM-V under Section 3. Which is a section for emerging measures and models. And it's a condition that DSM considers as a condition for further study. What this means is that basically the editors of DSM-V, for those of you who are not familiar with DSM, the DSM is the Diagnostic and Statistical Manual of Mental Disorders. Now it's in its 5th edition. It was published in 2013 and is basically the diagnostic manual of the American Psychiatric Association. So is the manual of is the main manual for diagnosis, at least in North America. So the people working on DSM-V thought that there was not enough evidence to consider persistent complex bereavement disorder, basically to consider a grief-related disorder as an independent diagnosis in DSM-V. So they included a grief-related disorder that they called persistent complex bereavement disorder under the section for conditions for further study. And they suggested some symptoms of persistent complex bereavement disorder. This is an example. Of course, the individual should have experienced the death of a loved one. Symptoms should persist for at least 12 months in adults and 6 months in children. And this is the list of symptoms that currently are suggested for persistent complex bereavement disorder. So there's persistent yearning and longing for the deceased, sorrow and emotional pain. There are, etc. There are symptoms that describe a reactive distress to the death, such as marked difficulty accepting the death, emotional numbness, excessive avoidance of reminders of the loss. And then there are symptoms that describe disruption in social life and disruption in identity, such as the desire to die in order to be with the deceased, difficulty trusting other individuals, difficulty to pursue interests and plan for the future. So as you can see, a lot of these symptoms are actually similar to symptoms of post-traumatic stress and symptoms of major depression. So there's a lot of, at least from the point of view of symptoms, there could be a lot of overlap between these three disorders. So again, going back to the previous question, is like, do we need a new grief disorder, a new grief-related disorders, or can grief reactions be explained by existing disorders such as post-traumatic stress disorder and major depression? Usually new disorders in psychiatry, at least, should be created only when it's necessary. So it is important to think, it's important to consider whether clinically significant grief reactions can be better explained or incorporated into existing diagnostic entities such as major depression or PTSD. So the question that was not answered before DSM-V was published is, do we need a new bereavement-related disorder? Like, do we need a new grief-related disorder in psychiatric nosology? To answer this question, there are a lot of sources of evidence that you can examine. You can examine the course of the disorder, the prognosis, the treatment. You can do family studies, genetic studies. We didn't have data to do any of that. So we didn't have longitudinal data. This was a cross-sectional study, and we didn't have genetic data or information at the family level. So the things we could do to answer these questions were examine 4 sources of evidence to establish if a new grief-related disorder is necessary in psychiatric nosology. So we examine whether the predictors, the clinical correlates, the symptom structure, and the phenomenology of grief are distinct and independent from those of post-traumatic stress and major depression. Post-traumatic stress and major depression in the grief literature are often referred to as the nearest neighbors of grief, meaning that they're very much related to grief reactions. If some of these terms are not clear, like phenomenology, etc., I think this should be clearer later when I will show the results. As I said in the previous slides, a lot of symptoms of grief resemble symptoms of post-traumatic stress and symptoms of major depression. The same is true for the predictors of grief. So this is just a note about the predictors of grief, PTSD and MDD. So again, not only the symptoms are related, but also the predictors, especially when grief reactions are the consequence of the death of a loved one that happened under traumatic circumstances, such as 9/11. As I said, this is a sample of children and adolescents that was assessed 6 months after 9/11. So all the children who are bereaved in the sample were bereaved because of a traumatic loss, right? The loss of a loved one that happened on 9/11, or as a consequence of 9/11. So when the loss is traumatic, loss and trauma-related events often overlap. So if you think about a situation such as 9/11, the traumatic loss is overlapping with other traumatic experiences that the children and adolescents might have experiences, such as like their own direct experience of trauma. So there's a lot of overlap, especially with this type of mass traumatic events. So post-traumatic stress and persistent complex bereavement disorder can have common precipitating events, meaning they have common triggers, common let's say environmental risk factors, when the death of a loved one is the result of a violent act, such as September 11. The situation is it's complicated by I mean, not complicated, but I think it's just another way of showing how loss and traumatic related events can be highly overlapping. In DSM-V included a traumatic bereavement specifier in the proposed diagnosis for persistent complex bereavement disorder. So this raises even more questions about the distinction between grief reactions related to traumatic bereavements and symptoms of trauma-related disorders such as PTSD. So if the loss, meaning that if the loss of a loved one happened under like violent and circumstances such as the attacks of September 11, the reaction that the bereaved individual has, is it better described as a grief reaction, or is it better described as a PTSD reaction, or is it both? So these were all questions that were not answered in 2013 when DSM-V came out, and actually for the most part there's still debate about these questions currently. So this paper was this study was an attempt to at least answer some of these questions. This study sought to replicate and extend previous findings to a representative sample of children and adolescents that were exposed to shared mass traumatic events, 9/11. I say replicate and extend previous findings because there have been studies about that examine the relationship or the similarities and differences between grief and post-traumatic stress, or grief and major depression. There have been studies in children and adolescents, but there were very few, usually small samples, and usually they examine only one or two questions. Maybe they examine the differences in the predictors or differences in the factorial structure of these disorders, but it was never like a comprehensive study that examined all of these four sources of evidence, and in such a large sample that like the one we had. So the aim of the study was, as I mentioned at the beginning, was to examine whether the predictors of grief, the clinical correlates, the factorial structure of grief, and the phenomenology of grief are distinct and independent from the ones of post-traumatic stress and major depression. To answer these questions, we examine a sample. It's called the World Trade Center Board of Education study sample. It was more than 8,000 public school students in grades 4 to 12 in New York City. When the study was conducted 6 months after 9/11, it was representative of all of the New York City public school population at the time, at least like the children in the grades 4 to 12. So it was representative of more than 700,000 New York City public school students. We defined bereaved youths as children and adolescents who experience the loss of a family member, such as mother, father, sisters, etc., the loss of a friend, and or the loss of someone else on 9/11, of course. So we created three variables: children who experience the death of a family member, it's a little bit less than 300 children; death of a friend, a little bit less than 600 children; and death of someone else they knew, which is just a little bit more than 1,000 children. So in total, we had almost 1,700 youths who were bereaved on 9/11. And this was representing almost 20% of the New York City public school population at the time. Again, at least the public school children in grades 4 to 12. Well, this is just this is the measure that was used for grief. It was actually a very short screening measure for grief. Only 5 symptoms of grief were assessed. The measure is called University of California, Los Angeles Grief Screening Scale. It measured the intensity of grief reactions on a Likert scale, like a 3-point Likert scale, from 0 for not at all, 1 somewhat, and 2 for a lot. These were the symptoms of grief that were assessed. So the child missed the person who died. The respondent had to say if they were missing the person who died, not at all, somewhat, or a lot. Same thing for the other symptoms: avoidance of activities that remind of the person who died, recurrent and intrusive thoughts of the person who died, still feeling this sense of connectedness with the person who died. So the person who died is still an important part of the respondent's life, and avoidance of conversations related to the person who died. As you can see, again, a lot of the symptoms, actually, I mean, just think about the symptoms of avoidance. These are pretty much the same symptoms that you find in post-traumatic stress disorder. And the same thing for recurrent and intrusive thoughts of the person who died. This is the symptom is very much overlapping with symptoms of post-traumatic stress disorder. So again, going back to the original question, is like, do we need a grief disorder? Do we need an independent grief disorder in DSM-5, or can grief reactions be explained by post-traumatic stress or by major depression? So let's just go back to this slide. Sorry. As I said, grief reactions were on a 3-point Likert scale. For some of the analysis that we did, we needed dichotomous items. So since we have a 3-point Likert scale answers here, we needed to dichotomize the items. The question was like, do we consider as negative symptoms that are scored as 0 and as positive symptoms that are scored as 1 or 2, or do we consider as negative symptoms that are reported as like 0, not at all, and 1, and we consider as positive only if the respondent says a lot. So it's I'm just going to show you what we did. Again, there's a lot going on here, but it's just for you to, it's just a way to say that item response theory analysis, it's a very good way to decide what I just said in an empirical way, and not based on theory or some sort of assumptions. So there's we don't have to explain everything that is shown on this slide. But I just want to point out that on this, let's say on this panel, these are results for when symptoms are considered negative if the answer is 0, and they're considered positive if the answer is 1, meaning somewhat or a lot. And here is item response theory results for the other way of scoring grief reactions. So in this case, symptoms are considered as negative if the answer is 0 or 1, and they're considered as positive only if the answer is 2. So there's item response theory analysis generates several results. For now, I just want to focus on the test information function or test information curve for this way of scoring symptoms. As you can see, the test information function peaks around 0. So as you can see, the peak is 0. 0 is the mean, the standardized mean of grief reactions in the sample. So these are standard deviations. 0 is the standardized mean. So in this case, the test information function tells you that this way of scoring PTSD reactions gives the largest amount of information more or less around the sample mean. So what this shows is that what this says is that the grief scale that we used, if items are scored this way, it's good to measure grief reactions that grief reaction severity that is around the average in the sample. So not very severe grief reactions. But if grief reactions are scored this way, so only answers that were 2, so meaning like the grief symptom bothers me a lot, so only in this case we consider the grief item as positive or as present, then the test information function shows that the grief scale in this case gives the largest amount of information, or let's say becomes very, very good to measure grief reactions, more or less at a severity that is 1 standard deviation, actually a little bit more than 1 standard deviation above the sample mean. And this is usually what you would expect from a measure that has some sort of clinical relevance. And again, like different settings, different contexts require different measures. But I think in this sample, if you have a measure that is good at, if you have a tool, like a screening tool that is good at measuring grief reactions only around the sample average, it means that you're not really capturing moderate to severe grief reactions. So I think the best way is to have the best thing would be to have a measure that captures grief reactions that are at least like 1 standard deviation above the sample mean. For screening purposes, you don't want this curve to be too much to the right. So in general, you don't, when you're screening individuals in a large population, you don't want a measure that just captures individuals who have very severe grief reactions in this example, or very severe, major depression and post-traumatic stress disorder. But you don't also, but at the same time, you don't want a measure that is good at, measuring individuals who are not severe, who are actually who have average grief reaction. So you want something in the middle. So that's why we decided to score as positive only items that were only items that were originally scored as 2. Anyway, this is just for you to know, in case you're in case you're facing similar issues with scoring some of your items or symptoms. We had other measures. Of course, we had measures of post-traumatic stress and major depression. We had a measure of functional impairment, meaning how much was the respondent's life impaired by the way they were feeling. For example, the parents were worried and concerned about the child. The parents or the teacher got annoyed and upset with the child. The child was unable to go to places or do things with the family and with other people because of the way she or he was feeling, etc. So we had a measure of functional impairment. We used measures of new health problems since 9/11. We created 2 variables, a dichotomous variable for reporting any new health problems since 9/11, and a sort of like a continuous variable for total number of new health problems. And then we had measures of exposure to the World Trade Center attack. In addition to the variables that I showed before about experiencing the death of a loved one, we had other measures of so-called indirect exposure, meaning exposure that involved a family member, a friend, or someone else that the child knew. So we created 3 variables for knowing a family member, a friend, and or someone else was hurt in the attack. So 3 variables, 1 for family member, 1 for friend, 1 for someone else, and 3 variables for knowing a family member, a friend, or someone else who was in the World Trade Center area but escaped from the area without being hurt. We had measures of direct exposure to the attacks. So like, for example, personally witnessing the attack, being hurt in the attack, etc. And we had measures of media exposure to the attack. So, for example, a lot of time spent learning about the attacks from television, with and without adults, so 2 variables. A lot of time spent learning about the attacks from websites and or from radio, newspapers, and magazines. So these were the other measures that we used. All right, so the first source of evidence that we examined to determine whether we need a new grief disorder in future edition of DSM-5. So in this case, to examine whether grief is distinct from major depression and post-traumatic stress. First source of evidence was to examine, as I said, whether the predictors of these 3 disorders are different. So what you see here, these are the outcomes: grief, post-traumatic stress, and major depression. These are the predictors, demographic variables, and then the variables I just mentioned. So variables measuring indirect exposure, loss, direct exposure, media exposure. What we did was a stepwise regression analysis. So what you see here are only the variables that made it to the final step, that made it to the final model. So variables that were not at all associated with the outcomes at previous steps were excluded in the final step. So you don't see all of the variables that I just mentioned here. You just see the variables that made it to the final models. For each outcome, the regression analysis were either unadjusted or adjusted for the other 2 disorders. So for example, if you look at column 1, this is the association between these independent risk factors or independent variables and grief without adjusting for post-traumatic stress and major depression. Column 2 is the same predictors, but analyses are adjusted for post-traumatic stress and major depression. Same thing for the other outcomes. So you have, when the outcome is PTSD, you have analyses that are unadjusted for the other 2 disorders, so grief and MDD in this case, and then you have analyses that are adjusted for MDD and grief in this case, and same thing for major depression. So, okay, the main question here was, are the predictors different? The answer is yes. As you can see, loss-related variables, in this case, experiencing the death of a family member, the death of a friend, the death of someone else that the child knew. These variables were very much strongly associated with grief. No matter if the analyses were unadjusted for post-traumatic stress and major depression, or adjusted for post-traumatic stress and major depression, you still find a very strong, very significant and very strong association between loss-related variables and grief. The same is not true for the other disorders. So actually, these variables are not at all associated with major depression. And experiencing the death of a family member was associated with PTSD. But when you adjusted the analysis for grief and for major depression, you don't find a significant association anymore. So this means that experiencing the death of a family member is a predictor of post-traumatic stress disorder. But once you take into account in the analysis grief and major depression, then you don't find a significant relationship anymore. Again, the same is not true for grief. Even if you adjust for the other two disorders, so even if you take the fact of the other two disorders into account, you still find a very strong relationship between loss-related variables and grief. So, so loss-related variables seems to exclusively predict grief and not other disorders. Another example is direct exposure. Direct exposure variables are instead not associated with grief, and they are associated with post-traumatic stress disorder, no matter if you adjust for the other two disorders or do not adjust for the other two disorders. So there are some other examples that can be made here. There's some differences also in demographic variables, but again, maybe the main point here is really like the main example here is these two sets of variables. So the question, are the predictors of these three disorders different from each other? The answer is yes. Loss-related variables are exclusively associated with grief. Direct exposure variable are exclusively associated with post-traumatic stress disorder, and actually none of these variables are associated with major depression. In general, the variables that we use for this study were not good predictors of major depression. So so probably major depression in this sample was predicted by variables that were not either were not included in this analysis or were not measured in the sample. But so this is just the answer to the first question is that the predictors of these three disorders are distinct and different from each other. The second question is the incremental validity of grief. This is just a fancy expression to say that the clinical correlates to examine whether the clinical correlates of grief are different from the clinical correlates of major depression and post-traumatic stress disorder. By clinical correlates, the clinical correlates we had in the sample are some of the variables I mentioned before: new health problems since 9/11 and functional impairment. So the question is grief independently associated with new health problems and with functional impairment, even if I control for post-traumatic stress and major depression? So do I find a unique relationship between grief and health problems and grief and functional impairment that is not explained by post-traumatic stress and major depression? And the answer was yes. So these were the independent variables that were entered at the same time in the regression models. These are the outcomes. When the outcomes were new health problems, no matter if we use a dichotomous outcome for any new health problem or a continuous outcome for the number of new health problems, as you can see, post-traumatic stress and major depression were pretty significantly and strongly associated with these outcomes. We only found a marginal relationship between grief and any new health problem. But when we looked at functional impairment, we did find a significant and, let's say, relatively strong relationship between grief and functional impairment, defined as a dichotomous outcome. And we found a pretty strong relationship also between grief and the impairment score. So we found a pretty strong relationship also when we use a continuous outcome to quantify impairment. And the results were significant, even if we included in the model, in the regression model, post-traumatic stress and major depression. So even if you control your analysis, or you adjust your analysis, whatever you want to say, for post-traumatic stress and for major depression. So even if you take into account the effect of post-traumatic stress and major depression on functional impairment, we did still find a significant relationship between grief and impairment. So this was the second source of evidence. This shows that you sort of like need grief reactions. You need to measure, you need to know about grief reactions if you want to explain functional impairment in your sample. PTSD and major depression are not enough. Factorial distinctiveness. Factorial distinctiveness, again, it's probably just another confusing expression to talk about factor analysis. This was another source of evidence. So consider that this is a sample of youth that was bereaved on 9/11. So these are youths. All the analyses I've shown so far were actually done in the whole sample. So like more than 8,000 children. The factor analysis was done only in the sample of bereaved youth. So about 1,700 children that were traumatically bereaved on 9/11. And it was pretty, maybe surprising, I should say, to see that grief reactions, these are the grief reactions, these are PTSD symptoms, these are major depression symptoms. All of the grief reactions loaded only on one factor, which was, by the way, the factor that in this sample of bereaved youth explained the largest proportion of variance in the sample. While symptoms of post-traumatic stress and symptoms of major depression loaded on separate factors. So this was another source of evidence. It basically shows that the sources of covariation between grief reactions in the sample are explained only by one factor that is specific for grief reactions. The same thing can be said for PTSD symptoms. So grief reactions are actually loading, grief reactions only load on one factor. PTSD symptoms load on three factors that are specific for PTSD. By the way, these findings sort of are in agreement with previous studies about the factorial structure of post-traumatic stress. I don't think anybody ever examined the factorial structure of grief symptoms, post-traumatic stress, and major depression symptoms in children and adolescents that were traumatically bereaved. So I think this was the first study. So what I want to say here is that there's a lot of things that can be said. As, for example, as usually is the case in psychiatry, symptoms of different disorders are correlated with each other. Different disorders are correlated with each other. You find something similar here. As you can see, the factor underlying grief reactions is correlated. These are correlation coefficients, is correlated with factors underlying the other disorders. But despite these high levels of correlations between factors, factor analysis still found that only one factor, only one specific factor only for grief reactions. So there were no symptoms of other disorders that were loading on this grief factor, and there were no grief reactions that were loading on factors that were underlying other disorders. So this shows that, again, the sources of covariation, the sources of correlation between grief symptoms in your in this population are explained by only one factor that is specific for grief reactions. So basically, there is no overlap between factors underlying symptoms of grief, post-traumatic stress, and major depression. The last source of evidence was phenomenological distinctiveness. Phenomenology is just a way of talking about symptom profiles. Phenomenology means the way symptoms of a disorder or symptoms of several disorders present themselves in patients, present themselves in a sample. To answer this question, or to examine symptom profiles, we did a Latin class analysis. Latent class analysis is, when we did a Latent class analysis, again, only in the sample of bereaved youth, so in 1,700 children. Latent class analysis is a very good way to group individuals based on similar symptom profiles. So in other words, it's a very good way to group individuals based on their probability of endorsing certain symptoms. In other words, people who are grouped by latent class analysis in one class have very similar symptom profiles, so have similar probabilities of answering, of having whatever symptom you measure in your sample. So on the horizontal axis, I reported PTSD symptoms, major depression symptoms, and grief reactions. On the vertical axis is the probability of having all of these symptoms. The best fitting model in the sample was a 6-class model. What we were interested in finding was a class, meaning a group of individuals that only had severe grief reactions, not comorbid, so not co-occurring with post-traumatic stress and major depression symptoms. Because again, if we want to understand whether we need an independent grief-related disorders in future edition of DSM-V, you do want to show that, I mean, it is expected that, like it's always the case in psychiatry, you do find comorbidity between a disorder and other disorders, but you also want to find that, you also want to see that the disorders can occur by itself. So it's not always comorbid with other disorders, because again, the question then would be like, do we really need this new disorder? What we found, if you look at individuals in this class number 2, the red line, you see that these individuals, compared to other classes, have very high probability of reporting grief reactions, again, compared to other classes, and very low probability of reporting major depression symptoms and symptoms of PTSD, except recurrent thoughts of what happened at 9/11. This was the PTSD symptom that was very prevalent in this population 6 months after 9/11. And again, this is expected just because, as you can imagine, 6 months after 9/11, the media and everybody was still talking about 9/11. So it was very, it was very common. It was very normative in a way to still have recurrent thoughts of 9/11. But regardless, the point here is that children and adolescents in this class only have severe grief reactions and do not report symptoms of major depression and PTSD. We did find another class, a small class that had actually the highest probability of reporting grief reactions, and also had moderate probabilities of reporting major depression and PTSD symptoms. Is the class number 1, is that the black line. So these people have, in other words, these people have severe grief reactions, or a high probability of having severe grief reactions, and also have moderate probabilities of reporting major depression and PTSD symptoms. So as far as grief is concerned, like these analyses show that in a sample of bereaved youth, you can find 2 distinct classes of individuals with high severity of grief reactions. A class that is a class of individuals with severe grief reactions that are non-comorbid with major depression and post-traumatic stress, the red, this red line that I was talking about before, and a class of individuals that has severe grief reactions and also moderate symptoms of major depression and post-traumatic stress disorder. There's a lot of other information you can gather from this type of analysis. For example, it was and this is not related to grief, but it was interesting to see that we did find a class of individuals who only had severe major depression symptoms, like severe symptoms of major depression is the blue class, and very low probability of reporting symptoms of PTSD and symptoms and grief reactions. So this class was mainly defined by severe major depression. And interestingly, we did not find a class of individuals only with severe post-traumatic stress symptoms. As you can see, if you look at this if you look at this line, individuals in this class number 3, have very high probability of reporting PTSD symptoms, but they also have pretty high probability of reporting major depression symptoms and no probability of reporting grief. So in this sample of bereaved youth 6 months after 9/11, we did not find a class of individuals who only had post-traumatic stress symptoms. This type of results, like examining symptom profiles, I think is very important also for treatment prevention, and to like really to understand from a purely clinical perspective what's going on in your sample. It is interesting to see that in bereaved youth after 9/11, you do not find individuals who only have symptoms of post-traumatic stress, meaning you basically see that individuals who have severe symptoms of post-traumatic stress also have severe symptoms of major depression. But the same is not true for major depression. You do find individuals who have only severe symptoms of major depression and no symptoms of post-traumatic stress or grief. So this type of consideration is very is clinically very useful. We then use these classes to predict functional impairment and health problems, like the same, similar to what we did before in the whole sample. And we did find when we combine the classes of individuals that reported severe grief reactions compared to individuals who had no symptoms at all, we did find that individuals in these classes, so individuals who had severe grief reactions, had also, if you look on the left, had also higher likelihood of reporting any new health problems since 9/11. They had a higher likelihood of reporting functional impairment, and they also had a higher impairment score. So among bereaved youths on 9/11, youths who have severe grief reactions compared to children and adolescents who have no symptoms, youth who have children and adolescents who have severe grief reactions have higher likelihood of reporting new health problems and being functionally impaired. The same was not true for people in the other two classes I mentioned, so people who have severe major depression reactions and severe post-traumatic stress and major depression reactions. If you compare these children to children who have no symptoms, you do not find that children in this class are more likely to have new health problems and being functionally impaired. In other words, in this sample of bereaved youth, the children who were functionally impaired and children who had new health problems were only children who had severe grief reactions, not the children who had severe post-traumatic stress and major depressive reactions. This is something that was not previously published. I don't know if some of you listened to the talk I gave at this conference on Tuesday. This is the first step so this is the first step of a machine learning study I'm working on. We applied a very novel machine learning algorithm for causal structure discovery to the same sample and the same variables I just talked about. This is a machine learning algorithm for causal structure discovery that can determine the causal relationships between all of the variables that you entered in the model. So let's just focus for now on the green arrows. Green arrows are arrows that represent direct relationships between one variable and another variable, and relationships that are not confounded by variables that were not entered in the model. And I don't think we need to go into the details here, but in this network analysis, this causal network analysis, in which the machine learning algorithm connected all of the variables that were entered in the model, what you see is that grief reactions was causally associated with impairment indicators. So PTSD was also associated with impairment indicators, but you do find a significant and direct causal relationship between grief reactions and impairment indicators in your sample. So this is another source of evidence to show that grief reactions are not only associated with impairment, and as we showed in the previous analysis, but they're actually causally associated with impairment. So grief is a cause of impairment in this sample. Some conclusions. There's convergent support from these 4 different sources of evidence, and actually also now from the machine learning results, the causal structure discovery analysis that I just showed. There's convergent support excuse me, that grief reactions in children and adolescents who were traumatically bereaved on 9/11 represent a clinically meaningful and unique aspect of bereavement-related distress that is not described, is not captured by other forms of trauma and bereavement-related maladjustment, such as post-traumatic stress and MDD. The different sources of evidence that I showed were the predictors. So there's a distinctiveness of predictors, meaning the predictors of grief, post-traumatic stress, and major depression are different from each other. So loss-related variables were not associated with major depression. Traumatic bereavement was associated with PTSD, but was not significantly associated with PTSD once we took into account grief reactions. So when the results were adjusted for grief reactions. Bereavement or like loss-related variables were strongly associated with grief reactions, even if we control for PTSD and major depression. And direct exposure variables were only associated with MDD. Incremental validity of grief, meaning are the clinical correlates of grief, post-traumatic stress, and major depression different? Sorry, not different, but it's like, is grief necessary to explain some other negative outcomes, such as new health problems since 9/11 and functional impairment? And the answer again was yes. Grief reactions uniquely contributed to functional impairment, even if we control for post-traumatic stress and MDD. So in other words, there is something about functional impairment in this sample that is not explained by post-traumatic stress and major depression. So you do need grief reactions to understand or to explain functional impairment in this sample. The factorial distinctiveness of grief, meaning the results from factor analysis, grief reactions loaded on a separate factor. And as I said before, I think this result is especially notable because we're talking about traumatically bereaved youth. So these are not youths from the general population. I mean, these are youths that were traumatically bereaved on 9/11. And again, a situation in which loss related events and personal traumatic related events are highly overlapping, a situation in which there were multiple traumatic experiences going on at the same time. So even in this situation, we did find that grief reactions loaded on a separate factor that was specific for grief. And the phenomenological distinctiveness, there is the latest result, or some of the latest results I showed about the latent class analysis. We did find 2 classes with high probability of reporting grief reactions. One class had also moderate probability of reporting post-traumatic stress and MDD symptoms, but there was one class, and this is important, one class that only had high probability of reporting grief reactions that were not comorbid with post-traumatic stress and major depression. So the study support the potential clinical relevance of a new bereavement-related disorder. Grief reactions have added clinical value and merit clinical attention because they describe maladaptive reactions after 9/11 that are not adequately captured by other disorders, such as post-traumatic stress and major depression. These findings, yes, an important finding was really to see that grief reactions are independent predictors of functional impairment. So these findings suggest that the primary benefit of establishing a new grief-related or new bereavement-related disorder in future edition of the DSM, one of the benefits would be to fill in a current gap in describing, in explaining, in measuring, and also eventually, intervening on reactions to traumatic bereavement. I just want to point out again that most studies of grief in general, not only treatment studies of grief, but actually most studies of grief in general are in adults. So it is important to develop and evaluate specific treatment methods for youths that are traumatically bereaved. These are important challenges for the future. if you think about the results from the latent class analysis, for example, I showed that there was a class of children, a group of children and adolescents who only had severe grief reactions, and there was a group of adolescents and children and adolescents who had severe grief reactions that were comorbid with post-traumatic stress and major depression. So these two groups of individuals might need different treatments. So if you only have severe grief reactions, you might need a certain type of treatment. But if you have grief reactions that is comorbid with post-traumatic stress and major depression, this is supposedly a more severe class that might need a specific type of treatment. We have like probably 3 minutes left. So these are just some considerations about grief, post-traumatic stress, and major depression in DSM-5. So at the moment, as I said, there is no diagnosis for grief. At the moment, you don't really know what to do if somebody has severe grief reactions. So in the diagnosis of post-traumatic stress in DSM-5, the DSM-5 does acknowledge the fact that when the traumatic events produces violent death, like in the case of 9/11, there could be symptoms of both problematic bereavement and PTSD, although there is no diagnosis at the moment for problematic bereavement. The DSM-5 diagnosis for acute stress disorder makes a similar statement. It says that in the case of bereavement following a death that occurred in traumatic circumstances, symptoms of acute stress disorders can involve acute grief reactions. Again, there's no official diagnosis for grief reactions. I think, as far as I know, I may be wrong, but I don't know. I think the only thing you can do in DSM-5 now would be to diagnose somebody who has severe grief reactions. You could diagnose this individual as having an adjustment disorder. So DSM-5 does acknowledge that adjustment disorder may be diagnosed following the death of a loved one if the intensity, the quality, the persistence of the grief reactions exceeds what is normally expected based on cultural, religious, or age-appropriate norms. And DSM-5 does acknowledge that a more specific set of bereavement-related symptoms have been designated persistent complex bereavement disorder, as I mentioned at the beginning, although this is not an official diagnosis now, so you cannot make a diagnosis of persistent complex bereavement disorder. For instance, you cannot get treatment for it and get reimbursed by your insurance company because it's not an official disorder. There's something else to say about depressive disorders. I think we can just keep that now. But what I try to summarize here is it's this sort of like diagnostic vacuum. So you can diagnose somebody with an adjustment disorder. So, and what I want to say, what this shows is that acute stress disorder is only it's like less than a month from the occurrence of the trauma. For a PTSD diagnosis, you need to have PTSD symptoms at least for 1 month after the trauma, and the diagnosis can go on indefinitely. So you can have PTSD that lasts, more than 6 months, 9 months, 1 year, 1 year and a half, I don't know. But for adjustment disorder, DSM makes a specification. It says that you cannot diagnose an adjustment disorder after more than 6 months after the occurrence of the stressor that caused the adjustment disorder, or after the end of the consequences of the adjustment of the stressor that caused the adjustment disorder. So let's say if the trauma and the loss occurred here at 0, in theory, based on DSM, you could not diagnose somebody with an adjustment disorder after 6 months after the occurrence of the loss. So if you have severe grief reactions, you can get a diagnosis of adjustment disorder. The point is like what happened after 6 months after the occurrence of the loss. At the moment, there is really, I don't think there's a way to diagnose these individuals. These were just some considerations about grief and MGD. I think these slides, we're running out of time, so these slides will be available. This is just a way to show from a clinical perspective, in case you have to diagnose somebody, how grief and a major depression episodes can be differentiated from each other. just one example, if you have to diagnose somebody who might be depressed and also have symptoms of grief, consider that in grief, the predominant affect is feelings of emptiness and loss, but during a major depressive episode, the predominant affect is this persistent depressed mood and this inability to anticipate happiness and pleasure. These are usually not symptoms you find when somebody is going through complicated grief. Another example, I think a good example, is self-esteem. People who have complicated grief, in these people, usually self-esteem is preserved. Some people who experience complicated grief might have some self-derogatory ideation if they think that they should have done more for the person who passed away. So often people say, I should have visited, I don't know, my mother or my grandmother more. I should have told her or told him how much I loved her. So self-derogatory ideation is usually around these sort of themes, while self-derogatory ideation during a major depressive episode is really these pervasive feelings of worthlessness and self-loathing that are not anchored to specific events, sort of like a general pervasive feeling of worthlessness, which is actually also and the self-loathing is actually talking about suicide, is actually one of the strongest predictors of suicidal ideations in people who have a major depressive episode. Anyway, these slides will be available, so you can read more if you want. These are some acknowledgements, and I think this is the end of the presentation. Thank you very much.
Thank you so much for your presentation this morning. We're so happy to have had you with us this morning. Your presentation was certainly informative, and we really enjoyed it. As you said, the slide will be made available to everyone who attended, and also publicly available through our conference Facebook pages and posted, as well as we're going to be creating a drive with all of the presenter slides and presentations from this week that we've had of the Guyana Mental Health and Wellbeing Conference. So unfortunately, we are short on time, and I don't think we'll be able to do any questions. But thank you so much for your presentation.
Of course, thank you.